I'm joining you from Chicago today at the American College of Surgeons headquarters. And as Dr. Meredith said, I'm a general surgeon and acute care surgeon working at Las Vegas, where we have a level 1 program and a pediatric level 2 program. What's unique about my practice is that the level 1 trauma program is staffed by general surgeons who do the lion's share of care of children with oversight from our pediatric surgical and anesthesia colleagues. I've been chosen to speak to you about the principles and concepts around doing emergency laparotomy in a child from the perspective of a general surgeon. This happened just a few weeks before Christmas, and a 6-year-old male and his mom were hiking in the desert nearby Las Vegas. It's not uncommon that there are boulder rollovers there, and at least twice a year we see children injured by that mechanism. In this case, the child was pinned under the boulder. His parents helped push it off. He was brought into the trauma center, and on arrival, he had both hypotension and peritonitis. So he was taken directly to the operating room and explored through a midline incision. In the lower portion of the image, you can see that his duodenum was torn from the pylorus, his pancreas was transected, and his right kidney was shattered. Some of the important decisions about receiving a patient like this center around preparation. We've spent a lot of time in preparing around conference tables at M&Ms and specifically at pediatric department functions to plan and practice how we're going to receive and manage these children. We have a team that we've selected that rotates and knows their roles and responsibilities. I'll talk a bit about the incision decision. In children, the midline incision works quite well. It doesn't always have to be the entire midline. If you know the injuries are in the upper or lower abdomen, it can be tailored to that. And we'll talk about maneuvers to stabilize and resuscitate the patient while surgery is going on, while exposure is taking place, and then make the decision whether to repair the injuries that are found or to perform a damage control procedure and resuscitate the patient for return to the OR. The final topic will be how to close. Do you do a primary repair or a primary closure, or do you an open abdomen technique? In terms of preparing, planning, and practicing a selected team, each day while we're on call, we have a whiteboard, and up on the whiteboard we put on who's anesthesia, who's the trauma attending, who's the trauma team leader, our nursing, respiratory therapy, laboratory, radiology. Everything's on the board. And all these people know what to do should a patient arrive. You can practice this with mannequins. You can practice this with volunteers to give you some idea of what the flow is and the need to move equipment and personnel in and around the patient. As with ATLS, we begin with the primary and secondary survey. You've heard from other speakers what the caveats are surrounding the assessment of airway, breathing. What are the caveats for access for infusion of IV fluids and blood, and the assessment of disability and the external assessment for a trauma. When surgery is needed, as in the case I illustrated, it should never be delayed. Children are really quite fragile and they don't tolerate delays in care. The operating room should go into a routine where they immediately get the room warmed up. We installed some high-capacity heaters that heat the room up very quickly. In addition, we have all the normal warming equipment like blankets and forced hot air devices. Also, all the IV solutions are at 98.6 degrees, so they're normal thermic, and the blood products as well go through warming devices. And we have pediatric instruments that are readily available. So the resuscitation team is organized and practiced. It receives the patient. The surgeon in charge makes the decision for surgery. The OR team is child capable and practiced in that setup. Anesthesiology is pediatric experience. Most of the time we're fortunate to have somebody with formal pediatric training. Many of our anesthesiologists, though, as part of their routine practice, treat children and are comfortable in this role. And then after the event, after the resuscitation in the OR, it's important to debrief the team, to let them know what went well, what needs work, and to make a new list of equipment and training goals before the next patient comes. So at laparotomy, patients placed on the OR table in supine position, monitors and other devices like Foley catheters, NG tubes, IVs are all let up off the top of the bed. Then the patient is put on warming devices and prepped and draped with warm solutions. And the vertical midline incision is really the best way to get in with an undetermined diagnosis. The case we had, of course, arrives with blunt abdominal trauma plus peritonitis plus hypotension. There's no telling what we're going to find, and that midline incision worked just right. I believe that you need to start by packing from the quadrant of most likely injury, ending in the quadrant of least likely injury, and then also packing the midline. The most important thing in the first moments of the trauma laparotomy is to stop the bleeding. The contamination can be attended to later. There is a saying that you can't really develop sepsis or infection if you die from exsanguination. So always stop the exsanguination first. Once there's manual control through packing, you can begin unpacking. Unpack from the quadrant of least likely injury, ending in the quadrant of most likely injury. And in each of those stations, make sure you have hemostasis. And this can be performed with clamp and ligation, or it can be performed with electrocautery or other devices that might be available to you. While you're doing this is an ideal time to collect blood that's in the abdomen for autotransfusion. It's the best shot you have. Usually the majority of blood recovered is in the first moments of the case. So as you get those packs in, if you can be running the cell saver or running the autotransfusion device, that's quite helpful. And it allows anesthesia and the rest of the OR team to keep up with the patient's blood loss as they start to unpack the materials from the blood bank. So stopping bleeding is number one, no doubt about it. And if that's all you can get done, sometimes that's enough. Controlling contamination can be temporary, and the definitive control of contamination with restoration of GI tract continuity, that can come later. First, you must save the child's life. So stabilize the patient by stopping the bleeding, work with anesthesia to get the resuscitation underway, and understand that as a general surgeon, you may be used to doing cases in adults where you see a significant amount of blood, but in a child, even a small amount of blood is a significant amount of their blood volume. So talk and work together. Now I'll talk for a minute about damage control, and I'll close with temporary versus permanent closure. Damage control needs to take place when the patient exhibits signs of physiologic exhaustion. You cannot cure physiologic exhaustion with surgery. You can only cure that with resuscitation and care. So when a patient has hypothermia, acidosis, and coagulopathy, it's time to get out. The patient should be receiving close ratio blood transfusion of packed RBCs, platelets, and FFP. And if you need to get quick exposure, the pancreas can be best exposed through the gastrocolic ligament, retracting the stomach cephalad, and I'll illustrate this to you in a moment. The right side of the abdomen, particularly the kidney, the IVC, and the iliac, can be exposed by medial rotation of the duodenum and the right colon. And the left kidney and aorta can be best exposed by medial mobilization of the left colon with the spleen. This demonstrates how to get a look in the lesser sac at the pancreas, commonly injured in blunt trauma in children. Here, scissors used or bovi to go through the gastrocolic omentum, and then the stomach is retracted cephalad. This illustrates how to mobilize the right-sided viscera to the midline by releasing the duodenum, the so-called Coker maneuver, and then by releasing the right colon, which is the Cattell-Brash maneuver. And with that, the center photo shows how mobile the small bowel is on the pedicle of the superior mesenteric artery. And the left-sided mobilization is nearly the same. The spleen is released laterally as well as the left colon, and these are rotated medially. And the kidney can be brought up at the same time, and this does expose the kidney and the aorta. Well, damage control is a reasonably new term in, say, the last decade, and it comes from the naval definition, which is the capacity for a ship to absorb damage but to maintain mission integrity under any circumstance and at any cost. And that's exactly what the surgical mindset is for this procedure. Hemostasis above all else. Contamination can be temporary. And then you can delay these repairs until the patient's had their coagulopathy, hypothermia, and acidosis reversed. One of the ways to temporarily close the abdominal wall is with a vacuum-assisted closure device, which can be improvised or can be provided commercially. So you must end surgery when hypothermia, coagulation, and acidosis present. Closure of the abdomen is not necessary. The patient needs to go back to the ICU to have their physiology restored and their coagulopathy combated. And finally, return to the OR as soon as stable, not by some artificial selection of 24, 48, or 72 hours. The temporary abdominal closure using a VAC device is probably the most common. The abdomen is packed, covered with a plastic drape, and suction applied to that area. One of the complications are if it's left long-standing, it can result in fistulas or a chronically open abdomen. Really, if you're doing a vacuum-assisted device, you'd want to return to the OR and get that closure done definitively within a day or so. And alternatives to that, if you don't have this available, would be to create a prosthetic patch out of some inert material, use adhesive drapes, the kind that are widely available in operating rooms, or just to close the skin and leave the fascia open underneath. This is an example of a wound vac on a teenager. It works very nicely for the first 72 hours or so. We usually get back on these cases in less than 24 hours. We push the resuscitation to meet our targeted endpoints as quickly as we can. So even Einstein knew my secret, which is that trauma is really cool, and all you have to do is to stop the red stuff first and stop the brown stuff later. So what happened to that 6-year-old boy? Well, his duodenum and pylorus were closed and they were left in discontinuity. He had a distal pancreatectomy and a right nephrectomy. He had a Roux-en-Y gastrojejunectomy, and he had his abdomen closed in 24 hours with drains left in place, and was actually home with his parents in time for Christmas. So the new concepts that were presented today were the damage control resuscitation, which is that close ratio resuscitation simultaneous with surgical hemostasis. The damage control laparotomy, which is to stop bleeding above all else. And finally, that you can use the open abdomen technique temporarily as a window to bridge you to the next operation. I just want to thank you very much, and I look forward to your questions on the panel.
Dr. Fildes, thank you very much. That was very succinct. It was an excellent presentation, just what we were looking for.